Welcome to Podocyte Talk. Today we explore three impactful studies in nephrology that highlight advancements in anemia management for dialysis-dependent chronic kidney disease, treatment for recurrent complement-mediated glomerulopathies in post-transplant patients, and the timing and modality of kidney replacement therapy in pediatric chronic kidney disease. The first study focuses on Vadadustat, an oral hypoxia-inducible factor prolyl hydroxylase inhibitor, as a treatment for anemia in dialysis-dependent chronic kidney disease. This Phase 3b trial compared Vadadustat's once-daily and 3 times weekly dosing regimens with darbepoetin alpha, a widely used erythropoiesis-stimulating agent. The trial included a conversion phase, weeks 0 to 20, and a maintenance phase, weeks 20-52. Patients were randomized into 3 groups: Vadadustat once daily, Vadadustat 3 times weekly, and darbepoetin alpha. The primary endpoint measured changes in hemoglobin levels during weeks 20 to 26, with secondary evaluations during weeks 46 to 52. The results showed that Vadadustat once daily met the non-inferiority threshold with a least squares mean hemoglobin difference of 0.27 grams per deciliter compared to darbepoetin alpha, while the 3 times weekly regimen, with a difference of 0.53 grams per deciliter, did not achieve non-inferiority. From weeks 46 to 52, hemoglobin levels slightly favored darbepoetin alpha, but Vadadustat once daily maintained stable control. Fewer patients in the Vadadustat groups required rescue erythropoiesis-stimulating agent therapy, suggesting better anemia management. Adverse events and serious adverse events were comparable across all groups, indicating a similar safety profile. Overall, Vadadustat once daily offers a convenient and effective oral alternative for managing anemia in dialysis-dependent chronic kidney disease. The second study examines Pegcetacoplan, a targeted complement C3 and C3b inhibitor for recurrent complement-3 glomerulopathy and immune complex membranoproliferative glomerulonephritis in post-transplant patients. Both conditions are associated with high risks of recurrence and graft loss. The NOBLE trial, a Phase 2 multi-center randomized controlled study, compared Pegcetacoplan plus standard of care treatment with standard of care treatment alone. The primary endpoint was a reduction in complement-3C staining on renal biopsy at week 12, with secondary outcomes including changes in proteinuria, estimated glomerular filtration rate, and safety. The findings were promising. At week 12, 50% of Pegcetacoplan-treated patients achieved a reduction of at least 2 orders of magnitude in complement-3 staining, with many showing complete absence of staining and electron microscopy deposits, compared to only 33% in the standard of care group. Additionally, Pegcetacoplan-treated patients with baseline proteinuria, urine protein to creatinine ratio of at least 1,000 milligrams per gram, experienced a 54.4% median reduction in protein to creatinine ratio. These patients also showed stable estimated glomerular filtration rate, reduced plasma complement 5b9, and increased serum complement 3 levels. Safety data were favorable, with most adverse events being mild to moderate and no treatment withdrawals or deaths reported. Pegcetacoplan demonstrated efficacy, safety, and tolerability, offering hope for improved outcomes in post-transplant patients with recurrent complement-mediated glomerulopathies. The third study investigated the timing and modality of kidney replacement therapy in pediatric chronic kidney disease. This multinational, multi-center cohort study included 695 children aged 6 to 17 years enrolled in the Cardiovascular Comorbidity in Children with Chronic Kidney Disease study. Researchers analyzed factors influencing the initiation of dialysis or preemptive transplantation over an 8-year period. Of the cohort, 49% initiated kidney replacement therapy, with 200 patients starting dialysis and 142 undergoing preemptive transplantation. Factors influencing kidney replacement therapy initiation included lower estimated glomerular filtration rate at enrollment, a steeper decline in estimated glomerular filtration rate, and higher systolic blood pressure. Nutritional status also played a role, with lower body mass index and lower hemoglobin associated with earlier dialysis initiation. Patients with glomerulopathies were more likely to start dialysis compared to those with congenital anomalies of the kidneys and urinary tracts. Additionally, center-specific factors accounted for up to 8.7% of the variation in treatment timing and modality, emphasizing the influence of institutional practices. Thank you for joining us on Podocyte Talk. Check the episode description for links to these studies, and stay tuned for more cutting-edge insights in kidney disease research and treatment. See you next time.